Okay, so we're recording now. So to finish up the nosebleeds, of course, once the bleeding stops, you don't want them blowing their nose, okay? Because that will, of course, dislodge the clot, and then you'll have rebleeding. And that's about it. Oh no, this part I won't test because this is now for major bleeding. So let's say you have a busted artery, for instance, usually for trauma, then it'll be uh, managed with these balloon catheters now. This is the same principle as balloon tamponades, which we use for bleeding esophageal varices, for instance. You know, those people with liver cirrhosis who have, for lack of a better term, varicose veins in the esophagus. Those things can rupture spontaneously and bleed massively. Can cause hemorrhage actually. So if needed, you can't really stop the bleeding. Again, this is only for usually trauma. When you have a ruptured artery, then they'll employ these. Of course, if you have something hanging up your nose here, can you breathe?
No, up to your nose.
Right, so the patient will have to be a mouth breather while that is up in their nasal passage. These are some of the nursing interventions for management of bleeding. This, of course, is not for, not for major bleeds. So this is at home when you have um, minor nosebleeds at home. Most common cause is dryness. That's why this is common in the summer, although we do also have it during the winter, especially if it's too cold and then the air is just so dry. Um, so we get nosebleeds. Any questions?
No.
All right. So next topic on 29 is sleep apnea. Right here. Okay. What are the causes of sleep apnea? You guys have probably heard about this, um, Miss Christina.
Yes.
What are some of the causes or risk factors?
Obesity, large uvula, a short neck, smoking. Hold on, I can't see the rest of it. Oh, I gotta move this. Enlarged tonsils or adenoids, oropharyngeal edema.
Okay, very good. So most common, it's really the obesity. The problem with obstructive sleep apnea is it not only causes the accidents, because your only symptom really here is daytime sleepiness. So when you have a patient, um, they're not, how do I say this? They're not admitted because of a obstructive sleep apnea. They're admitted for the complications that result. One is, let's say, they fell asleep while driving, for instance, right? So because that's really the most common symptom. The patient uh, obviously can't get enough good night's sleep because look at the symptoms here. The patient awakens every so often throughout the night because the patient stops breathing because, as stated here, these structures here, the large uvula, short neck, all contribute to airway obstruction. And once the airway is obstructed, of course, you can't breathe, you are awakened, but you're sometimes between awake and asleep. So the patient doesn't really become aware that they were waking up so often, and then the patient after that episode goes back to sleep. But since you never really reach REM stage of sleep, so you're not really feeling well rested at all. As a result, you'll be tired. Sometimes you'll think, oh, maybe I have narcolepsy. which is not really. It's really obstructive sleep apnea. Some doctors, primary care physicians like mine, for instance, already have it in her protocol every year that she, if you fit the what is this the profile. So let's say if you're obese, you have a large neck, you have these, for instance, she will automatically have you answer a checklist evaluating you for OSA. And depending on your insurance, if you have good insurance, and they'll cover a sleep study, because this is the most accurate test to diagnose sleep apnea. And this is a good study because guess what you do at the sleep center?
Sleep.
Yeah, that's the best thing. That's the best part I can say about the disorder is during testing, they they let you sleep, and then they observe you. Of course, you won't sleep for 8 hours. Okay, you'll be evaluated during periods of sleep, and then record how many times you are awakened or how many times you actually go apneic during the episode. Let's go now to interventions. Of course, if we know the cause, so let's say it's obesity, you'll be advised to lose weight. It may be possible they'll just do a minor surgery, okay, on the uvula, decreasing the size. Um, well, we can't do anything about a short neck. Um, Stop smoking, or maybe, I don't know, remove your tonsils or remove adenoids, adenodectomy or tonsillectomy. That's those are minor surgeries. Although you are given general anesthesia for tonsillectomy, just because of the location. The cure here is really a long-term, non-invasive positive pressure ventilation. So this is in the form of a BiPAP or a CPAP. There's a drug mentioned here, but it's not really to cure the sleep apnea. It's really to manage daytime sleepiness, just to keep you awake. So the drug, of course, modafinil, is a stimulant just to keep you awake uh, enough to either finish school or get your work done. But otherwise, the patient would be put on a BiPAP or CPAP during sleep. So there are two variations in BiPAP. It stands for bi-level positive airway pressure. This is not exclusively used for obstructive sleep apnea. If you remember in chapter 35, this was also one of the therapies we use to manage heart failure. You remember this?
Yes.
Yeah, in heart failure. So the purpose of using this in heart failure was not really for obstructive sleep apnea, but um, for decreasing venous. Decreasing venous return slightly, not by a lot, only enough to decrease preload actually. So if there is less venous return, so that buys your heart some time by decreasing normal venous return. So in a way, it's really decreasing preload. Um, it's better than I don't know, intubating the patient. Plus, this one will also help expand the lungs, increasing oxygenation. But unlike a ventilator, this thing really doesn't give a breath. Okay, I don't know if you listen to Governor Cuomo's daily briefings. He mentioned this one time because there was a reporter was asking, if we can use BiPAP or CPAP if we run out of ventilators. And the answer was accurate, that he said they're not really the same. Okay, so BiPAP CPAP does not deliver a breath. It's not a ventilator. The patient has to be breathing in order to wear a BiPAP or CPAP. So what the machine does is it's positive pressure, delivering positive pressure, but not really a breath. Meaning you're breathing, but the objective here is to continuously deliver a certain amount of pressure, just enough to keep your airway open. So in BiPAP, there are two levels of pressure here. The pressure is slightly higher during inhalation, and then the pressure drops when the machine senses that you are exhaling. So it's much more comfortable because it only blows in the pressure, higher pressure during inhalation. And then when you're exhaling, it's not such a chore for you to exhale, meaning you're not really exhaling against pressure. CPAP, on the other hand, does not change pressure. CPAP will blow in the same amount of pressure whether you are inhaling or exhaling. As far as which one delivers better, it's really up to the patient's tolerance. Okay, but both do deliver positive airway um, pressure, and it has some degree of positive end expiratory pressure, meaning it does not allow the alveoli to completely go negative because it's constantly delivering pressure. So at the end of your exhalation, instead of the pressure inside the lung going to zero, it does not. Question? Hello?
No, Professor.
Okay, so there are different masks, just depends on the um, which model you have. And nowadays, the modern BiPAP CPAPs have smaller profile mask now. Some are even just over your nose, not the full face mask anymore. Although I still see full face mask BiPAP CPAPs in nursing homes, but they're going away because they're very uncomfortable. Because imagine you're a like a bigger than a scuba diving mask over your face all night. And that's about it. Let's see if we finish 29. Yes, we did. Okay. Let me go to 28, and that should be the end. I believe your blueprint mentioned about suctioning and oxygen delivery. Okay. Here is your best practice for patients receiving oxygen, because we did give oxygen to patients with pneumonia, COPD, and even patients with TB. All right, so this is your best practice when caring for patients receiving oxygen. This we won't go into invasive oxygen delivery devices, so this is just all external. So we have low flow and high flow devices, which will be on the next table I'll be showing you, but this applies to all of them. Include safety. Here we have, especially if it's a nasal cannula delivery, it will cause dryness of urinary, and that might lead to nosebleeds. Please take note that the bands we use, whether it's on a mask or the cannula, which go over the patient's ears, these are applying pressure on the skin. So make sure you watch the areas over the ear and also around the neck or even on the cheeks, especially if the patient is wearing these devices 24/7. For the nasal moisture, you can use water-based lubricants. Why can't we use petroleum jelly?
You can burn them, right?
It can act. It's petroleum based.
Isn't it too thick and it doesn't like the water based is more like dissolvable or
Yes.
easier dissolvable?
Uh-huh. So here, lubricate the patient's nostrils with non-petroleum cream. Okay. Plus, it's not really a good idea. There's a chance also this thing might catch fire because it's petroleum based and oxygen, not a good combination.
Yeah. And it will cause like buildup, right? To keep applying it.
Yes, that's another reason. This is a no-brainer. Of course, no smoking signs. However, you can't believe how many patients come in because smokers, especially those with stage COPD, they don't stop smoking anymore. They say, what the hell? They'll continue smoking. But of course, that shouldn't discourage us from still teaching them or encouraging smoking cessation. However, sometimes they forget. Let's say they wake up too early, go pick up a cigarette, light it up, forgetting that they still have the oxygen on. So it happens. It causes burns. Um, yeah. Uh, Here, oxygen technically doesn't burn, but because it's oxygen, it does feed the fire. So if you light up something, so it will make the fire. Um, okay, let me explain this principle right here of absorptive atelectasis. So this is the reason why oxygen. Remember we discussed and debated this in under COPD. We had quite a good debate on and discussion on oxygen administration for COPD patients. You remember that part?
Yeah.
Okay. Um, when we receive an order to administer oxygen, does it have to be on indefinitely?
No.
No.
No. So therefore, if the patient no longer needs it, you can always either titrate down or remove it. Of course, still notify the physician, but it's, I mean, you're a clinician also, so you make the determination. You're there 12 hours a day. You're the one at the bedside, so you're the one who knows your patients best. So if the patient is satting fine with less oxygen, then don't give oxygen. Okay. I remember a doctor. His last name was Balakrishnan. Of all the doctors in the hospital, he's the one that almost never gives his patients oxygen. You have to beg him in order to administer oxygen to your patients. If he walks in, makes rounds, sees his patients on oxygen, he'll chew you out, write you up, call the nursing director, call the yeah, he'll even call your mom, okay? Tell on you that you gave his patient oxygen. And this was his reason. No, room air contains oxygen. It's free. You shouldn't be giving oxygen. Anyway, that's according to him. Um, So room air is made up of, look at this, 79% nitrogen. So that means 21% is oxygen. Room air is 21%. So that will give you 100%, right? There's actually a little bit of percentage there of other gases, like there's fart air or CO2, right? Mixed in room air. But the point I'm making is it's not it's not good to give high oxygen concentrations, which is have you ever wondered what FiO2 means?
Isn't that like the amount of oxygen that like a patient's blood actually like is having circulated?
It's actually referring to the concentration of the oxygen that you are giving. So for instance, if the air you're breathing right now, the room air, is 21% oxygen. So the rest of it is nitrogen, mostly nitrogen. So if you start giving nasal cannula, that will increase it to 24% at 2 liters. And then at 6, probably you're at, I don't know, 28% FiO2. So FiO2 is the fraction of inspired oxygen, which is the concentration of oxygen being delivered. Now, if you read here, when high oxygen levels are delivered, of course, that drops the nitrogen concentration, right? You have more oxygen compared to nitrogen. The problem there is, remember that oxygen has to diffuse into the capillaries. When it reaches the lung, it diffuses inside the alveoli. So therefore, if you're breathing, let's say 28% oxygen, if that 28% diffuses inside, what's remaining in the alveoli? Meaning as air enters the alveoli, and it's, let's say, 28% oxygen. That 28% diffuses inside the capillaries now. What is remaining in the alveoli?
Is it the
Hello? What was that?
is it the CO2? If all the oxygen is
No,
gone?
before the exchange happens. So as the 28% oxygen is diffused, what's remaining in the air sac?
Nitrogen?
The nitrogen.
Isn't
Some nitrogen is left there. So as a result, does your lung, does the alveoli collapse?
No,
No,
nitrogen
because
prevents.
it's not going to all diffuse, right? So there's some gases left in the air sac, because nitrogen is a large molecule. It's not going to diffuse easily into the capillary. Okay, so only oxygen and CO2 will be able to pass in and out. Although some nitrogen, yes, it does enter. So the principle is, the higher your oxygen delivery, meaning let's say we change it to 100% oxygen, no nitrogen. Okay, so you put the patient on a non-rebreather mask and then put him up all the way, giving him 100% oxygen, 100% FiO2. So as that 100% diffuses inside into the capillaries, what's left in the lung? I mean, in the air sacs?
Would it be nothing because you didn't introduce any
Nothing.
nitrogen to it?
Exactly. So what will happen to the alveoli if there's nothing in it?
it's gonna collapse?
All right, so this is what we mean by absorptive atelectasis, meaning the lung collapses because you gave too much FiO2, okay?
Mm-hmm.
Too high of an FiO2. So always remember this phenomenon every time you give somebody 100% FiO2, okay? Because this can possibly happen. You're actually going to cause the lungs to collapse. I'm not saying we don't give 100% FiO2. Yes, we do that all the time, but only in short periods. It only should be maybe 1 or 2 hours. All right. So here, as stated here, so monitor the patient receiving high levels of oxygen every 1 to 2 hours, because it shouldn't be given longer than that. So it's safe to do this if the patient is on a ventilator, for instance, because when we have a vent, the vent has PEEP, meaning that, remember what we said about BiPAP CPAP earlier, that there is a positive expiratory end pressure, meaning the machine delivers some pressure at the end of exhalation, meaning it doesn't allow the alveoli to completely go to zero pressure. Remember that part?
Yes.
Yes, so that will make your high FiO2 delivery safer if you have PEEP. Okay, so again, if you're doing the oxygen, the high FiO2 delivery non-invasively using a mask, for instance, then it should only be for short periods of time. Even on a vent, if a patient's on a vent, the principle is, instead of increasing the FiO2, we can just increase the PEEP, or we can just add PEEP. Okay, because instead of increasing the oxygen concentration, why not just increase the pressure of delivery? Okay, because you can actually accomplish better oxygenation that way. The table here, this one, 28-1. So how is this tested? It's really on your understanding of, let's say, remember Mr. Because I know we were still in simulation earlier on this semester, and you, was it this semester or maybe last semester in 101? Remember Filberto Haggett, your patient who was American Indian, who was incontinent? You know, he was in for pneumonia.
And that smoked his herbal stuff.
Yeah, so
That was this semester?
That was last semester.
maybe 101, right?
Oh,
Yeah, so when you gave him oxygen, because his oxygen saturation obviously was less than 95, and it wouldn't go up, right? You kept increasing the oxygen, and you guys got frustrated. I remember Sonia, I facilitated your group. You sounded very frustrated during this simulation. You said,
Maurice Evasio. That's
uh,
the oxygen and hydration patient.
Arviso?
Arvicio. Maurice.
Yeah, maybe you're right. Yeah, maybe it was Maurice. Okay. But remember the scenario where you guys got frustrated because it just, for the life of you, it just wouldn't go up no matter how much oxygen you gave?
Yeah.
Okay, so this was the application now. So you know that a cannula, you can only give up to 6 liters, and that will give you 44% FiO2. And these are your nursing interventions when taking care of patients receiving it via nasal cannula. And here's a mask. Whenever a patient is wearing a mask, doesn't matter if it's a simple rebreather or a partial rebreather, when the patient vomits, remember the mask will prevent that emesis from coming out, so they could aspirate, okay, when wearing one. And this is of course your delivery. So at 8 liters, that can reach 55 to 60% FiO2, because none of these really are pure oxygen, meaning you have mixing of room air. That's why there's a no, it's not very high, because you're also breathing room air together with the oxygen. So that applies for nasal cannula, simple face mask, and a partial rebreather. Because a partial rebreather, let me see if there's a picture here. This is a simple mask. This one, partial rebreather. So although it has a reservoir, and the partial rebreather and the non-rebreather are actually the same mask. The only difference is if these ports are open, because they usually have a seal here of like a felt pad which will seal these exhalation ports. If they are on, that means there is no mixing of room air, meaning the patient is only breathing from the reservoir, which is oxygen only. So if the felt pads are still covering the exhalation ports, then that mask is a non-rebreather. If they're off, then that means the patient is breathing some room air, so it becomes a partial rebreather. And these are your nursing interventions. So the most important here is how much oxygen you're delivering with each device. Okay, there's only 4, so that's not too bad. Any question? And this should be it for chapter 29.
So how would you ask this a question based on this table?
Okay, so an example would be I'll either describe it or maybe I'll use a picture. I'll give you a patient.
Picture? Okay.
Yeah, I'll either use maybe this picture here or maybe this one or this one. And I'll give you the doctor's order, how much oxygen is running currently, and then the question would be, what would you do, or is this correct? Or so let's say you saw this is done by a nursing student when we intervene. All right. So it's all
Okay.
about oxygen safety. Do you know how to deliver oxygen? Do you know which oxygen delivery device to use?
Okay.
Based on the doctor's order.
So you're gonna give us the whatever the patient has and what type of mask he needs. Okay.
Right. Or I can give you, let's say, the doctor's order. So let's say doctor orders, okay, I want the patient to receive 75% FiO2. What delivery device can you use to achieve 75%?
Partial rebreather mask.
Okay, that's my point. So obviously the cannula and the face mask is out of the question. Okay, so
Okay.
it's either right. So you have to go with the high flow devices.
Okay.
Okay, again, this all
Thank you.
application, again, we're just trying to see, do you know how to deliver oxygen safely? Do you know which device to use depending on your doctor's order? Any question?
Thank you.
Okay. I've decided to just leave out, I think I put the topics on tracheostomy in your exam for the final exam. So I will you can remove that. We will only stop at this is a BiPAP, by the way. That's a picture of a BiPAP. Suctioning. You know what? I'll test suctioning in your 5th semester because that's really applied with a patient who has an artificial airway anyway. So you can remove the tracheostomy question, the suctioning. So we'll just have the oxygen delivery. Is that clear?
Yes.
Yes.
Yes, Professor.
All right, so let's take a break and then come back for chapter 21.
Professor, I have a question about that Google sheet that you sent.
Yes, boss.
How do I get to it?